I turn to Ranking Member Udall for any comments that he may make.
Good morning, and let me, excuse me, I first want to welcome Dr. Rubidoux and Acting Director McSwain, and thank you for joining us today, and we really appreciate you coming to discuss the fiscal year 2016 budget request for the Indian Health Service. And I'd also like to thank Chairman Murkowski for convening this important hearing. It's been many years since this subcommittee has held a hearing on the Indian Health Service budget, and I want to acknowledge her leadership in elevating this conversation. Healthcare for American Indians and Alaska Natives is an important issue, and I thank you for giving the attention it deserves. And just like she said, it's a burning issue in New Mexico, and it's also one, as she has expressed, in Alaska, and it certainly deserves our attention. Access to quality health care is incredibly important for the 22 tribes and pueblos in my state, but there's more to it than that. Throughout our nation's history, the United States has made a solemn commitment to provide health care through the treaties and agreement it negotiated with the tribes. We have to honor that commitment. Support for the budget of the Indian Health Service helps ensure that we do that. Congress has stepped up and provided significant increases for tribal health programs over the past several years, but we clearly have a lot of work to do, and we will do more. The President's budget for the Indian Health Service includes a 10% increase for health services and facilities needs, and I'm pleased to see that. Dr. Rubidoux, I want to commend the administration for fully funding contract support costs, which I know Chairman Murkowski also mentioned, and I look forward to discussing your proposal to authorize mandatory funding for the program starting in 2017. The budget request also proposes an increase of $70 million for purchased and referred care. These funds ensure that tribes can access to health care outside of the Indian Health Service, including preventive and specialty care. The request also includes new substance abuse and behavioral health investments for Native youth, which I look forward to discussing. And finally, it includes large increases for healthcare construction and maintenance programs. These funds are critically needed to repair aging hospitals and health clinics like those we have in my home state of New Mexico. This is a good budget request, but it's worth noting that it's only a down payment on the needs in Indian country. Tribal health spending per patient continues to lag behind the national average for health spending. The average medical spending per IHS patient, according to the Indian Health Service, was just $3,100 in 2014. That is less than half the average amount spent per patient for health services on a national basis, according to the Centers for Medicare and Medicaid Services. These funding limitations are a major factor in health disparities faced by our Native population, including higher rates of diabetes, suicide, and preventable illnesses. We need to close this gap, and we need to close it now. That's why I look forward to hearing more about the details of how your budget can improve health outcomes. And health outcomes, I think we really need to be discussing more and more, because that's what we want to see, Dr. Rubidoux. Appreciate you and Dr. McSwain appearing before us today, and thank Chairman Murkowski for working so hard on this issue. Thank you, Madam Chair. Dr. Rubidoux, your budget increases funding for purchased and referred care, which is known, I think, as the PRC, by $70 million above the fiscal 2015 level, which is an 8% increase. Patients depend on the PRC program to cover the cost of services not provided directly by the Indian Health Service, including emergency and specialty care. Your proposed increase is only a down payment toward the actual need for the PRC program. In 2014, you reported that 69% of PRC programs across the country were able to cover services beyond Priority 1, life and limb emergencies, and that means nearly one-third of the programs were unable to cover referrals for preventive care. That's clearly a huge demand for the PRC program funds, which means that even if Congress is able to support your request for additional funding, we may also ensure that every how may we also ensure that every dollar in this program stretches as far as it can? What progress would you expect to make towards expanding PRC services if Congress approves your budget request? Can you talk about how the funds will be allocated and whether they will be distributed to reflect the greatest needs on the ground?
Well, thank you. The need in the purchase and referred care program is enormous. If you look at the denied and deferred statistics from our federal and our tribal facilities, in 2013, $761 million was denied and deferred because of our funding levels not being enough to pay for all of those. So we're every dollar that we can get in an increase in purchase and referred care will mean more referrals. Related to this particular proposal, the increase could fund 980 more hospital admissions, 19,000 outpatient visits, 1,200 patient travel trips over the base funding if we get that increase. We are doing everything we can to spend that money efficiently. That's why we hire a fiscal intermediary to review all of our referrals and payments and make sure we're maximizing third-party collections so that we can save resources for those that don't have other resources. Our fiscal intermediary in 2013 was able to save us $1.1 billion in contracts, Medicare-like rates, and alternate resource savings that were negotiated as well. So we know these dollars are precious because every bit of them can pay for referrals for care that patients need. So that's why it's a top priority of tribes, and it's always been a top priority in our budgets over the last few years.
Now, you mentioned Medicare-like rates, and I have a question there. Your budget request includes a legislative proposal to charge providers Medicare-like rates for services, and the service has also proposed a rule relating to this new rate structure. Can you share with us what you expect the impact of this proposal would be in terms of dollars reinvested in care and additional patients treated?
There was a GAO report that said that on the federal side, the Indian Health Service could save around $32 million in purchased and refer cared funds if we were able to negotiate the lower rates with the outside providers that we pay for services. And so that's why we're trying to do everything we can on all levels to implement Medicare-like rates for non-hospital and physician services. And the notice of proposed rulemaking that went out in December, comment period is closed. The Indian Health Service is reviewing those comments, trying to find a way to make that work administratively as well. We know there's legislation pending that's actually better on the enforcement piece, but this is one where we're trying to push all the levers on this because the amount that we could save is millions of dollars, and that's just on the federal side. I've seen tribes estimate they could save like $60 million or more dollars if we were able to get these lower Medicare-like rates that we pay the outside providers.
Now, if you are proposing your own rule, could you address the need to have Congress, why you're requesting Congress to act on this issue, and why is the legislative proposal still necessary?
Well, the legislative proposal that we've seen does tie the Medicare-like rates to Medicare participation by those outside providers. So it has a much stronger lever than we're able to do administratively. And I know the tribes really prefer that legislation, but that's still working its way through Congress. And tribes have also asked us to try any and all options. So that's why the administrative solution is another option to be considered here.
Thank you. Thank you, Madam Chair.
Senator Udall.
Thank you, Chairman Murkowski. I really appreciate Senator Cassidy's comments and questions, and I hope that we can get the answers to those. I think it's important when we make comparisons, and I made the comparison about $3,100 a year, I think, approximately per patient, and how it's double in other circumstances around the country. And let's be fair with the comparison there and try to answer the question thoroughly. But and clearly IHS needs to be held accountable for what they spend, what you all spend. But I don't think these are the average patients. I think they have a higher disease burden. They live in remote areas where the provision of health services is more expensive. Their referrals for basic services, as Dr. Rubidoux, as I think you've said, are still being denied. So the idea that the Indian Health Service has enough funding at this point, I think, is incorrect. But I hope that you'll help us with that, and I'll probably submit a couple of questions too, so that you can answer that very thoroughly, and give us an idea of what the comparison is. You know, it was mentioned that if you had a private policy, it'd be a good private policy. Well, a lot of these people live hundreds of miles from physicians, and so if you had a private policy, then you'd end up exercising that option, which I don't think is a very good option for many Native Americans. And Chairman Murkowski, I'm glad you talked about retention. I'm really proud to have co-sponsored legislation with you on the scholarships and loan repayment programs funded through IHS, which I think this makes them tax exempt and to try to attract and keep people there. And so that's, I think, an important one, and we clearly need to do more there. Dr. Rubidoux, I'd like to talk about your request for health facilities in Indian Country. While I'm pleased that you've requested an increase of $100 million in your budget for healthcare construction, I know that the request only scratches the surface. I believe that Chairman said earlier, $2 billion, $100 million of funds that the IHS needs to fully fund its current construction priority list. In New Mexico, we've been waiting for years to receive funding to address the 4 aging facilities we have on the priority list, including the Gallup Indian Medical Center. You and I have both visited Gallup together, Dr. Rubidoux, and we both have seen firsthand how outdated the facility is. Tribes tell me that already it serves less than half the local needs, and yet we are still waiting. I know you share my frustration, and we're simply not making enough progress in replacing these facilities. So let's talk about the backlog. At your current rate of funding, how many years would it take to complete your current construction priority list?
I think I'll have to get you that specific number. It is dependent on appropriations. It is a $2.2 billion remaining need on the list that the Indian Healthcare Improvement Act says we have to complete before we get to the other $5 billion estimated need for facilities for everyone else. And so I've been to Gallup Indian Medical Center. I have seen the condition of it. The providers working there are heroes to be able to do what they do with the facility there. This president's budget helps us make significant progress moving down the list, so it would get us to Gallup Indian Medical Center sooner. And just I'm grateful for your comments about the data issue, and we want to work with you all on providing more data and more information to help you in your decision making on the budget. There's data and there's what we hear from the tribes, and the tribes tell us that there's still a significant need, and we hear that from our providers as well. And just appreciate your comments on if we're looking at the data, let's also remember the voices of the tribes who say there's a huge disparity in need as well, and we'll be happy to work on some of the data issues also.
Yeah. Well, it seems to me with the number you mentioned, the $2.2 billion and then $100 extra million, still the Gallup facility, I think, is $500 million. So I think that's going to be very, very difficult lift. And so that's why I think we need to see from you some kind of outside the box thinking of how we're going to address these kinds of construction needs. Previous administrations have come up with a 5-year plan or whatever it is. I mean, I hope you give some thought to that and then interact with us in terms of improvements there. Under the Indian Healthcare Improvement Act, IHS is due to make annual progress reports on its construction program. When can we expect to see your next report, and will it include estimates for the funds the IHS needs to construct all remaining facilities on the list, including the Gallup Indian Medical Center I've talked about?
Mr. Vice Chairman, I actually am, Dr. Rubidoux actually started an authorized Federal Appropriations Advisory Board made up of tribal leaders and and a couple of staff people, and they're actually been charged with coming up with the report for that's due next year. And they'll be doing a wide search. We'll be talking about consulting with tribes, particularly on the new authorities that are in the Indian Healthcare Improvement Act. But we will have the report prepared on time for submission the early part of next year.
Thank you.
Senator Udall, do you have any final questions here for us
Yeah,
this morning?
just thank you very much. Just a couple of quick ones here. Dr. Rubidoux, your budget includes $35 million in new funds to address sanitation needs in Indian Country, which is a 44% increase in the program. These funds are badly needed to make sure that homes in Indian Country have proper access to clean drinking water and wastewater disposal, especially since your budget estimates that 13% of these homes have no connection to sanitation facilities at all. Can you share with us how you expect to use these funds to improve public health? How do you propose to allocate the funds, and how many homes do you expect you'll be able to serve? What kind of progress will this proposed increase allow you to make?
Well, the need is significant. There's about $2 billion worth of need in projects that would be feasible to do. This particular increase would help us provide sanitation facilities to 7,700 Indian homes above the base funding. The Indian Health Service proposes in its justification to distribute this to both priority projects for existing homes and for new homes as well. And there's no doubt that any funding we can have in this area is going to help. You know, I've had the opportunity to visit very rural areas in Alaska and in other places, and it's just, it's heartbreaking to see that here we are in, 2015, and there's people that don't have sanitation facilities, don't have potable water. It's heartbreaking, and so that's why we're wanting to make some progress with this budget to propose the $35 million investment. It's not the entire need, but it certainly helps us get started on addressing that need.
Thank you. And shifting over to a quick question on dental care. There was language in last year's omnibus that encouraged IHS to work with the Bureau of Indian Education to provide Native youth with preventive dental care. As you know, Native American youth face far higher rates of childhood tooth decay and dental disease compared to the overall U.S. population. So providing these children with access to good dental services is critical and will help, I think, reverse these health disparities. Could you please update us on your efforts to improve dental care in the school setting, and will you work with me to make this a priority?
Absolutely, it's a priority. It's so important, good dental care. We surveyed our dentists recently in light of this request and found that in 9 of 12 areas, we already have prevention and treatment activities with 93 Bureau of Indian Education schools. So we've reached out to the BIE and would love to work with you on making sure we can increase access.
Thank you. I'm finished.